The beta hemolysis part, right? So the streptococci that undergo beta hemolysis and they have complete hemolysis, the bacteria completely destroy the RBCs around them, no hemoglobin remains, are basically two types. We have the group A strep and we have the group B strep. The group A strep is the strep pyogenes and the group B strep is the strep agalactiae. Now, for the beta hemolysis, we further do a bacitracin sensitivity test and PYR status test to determine which one is agalactiae and which one is pyogenes. Now, first, let's try to understand the bacitracin sensitivity test. Bacitracin itself is an antibiotic. Some streptococci are sensitive to it, and it's important one to know that the important streptococci that are sensitive to it are basically strep pyogenes. Okay, so the strep pyogenes has this zone of inhibition around it, but this other Agalactiae does not. This zone of inhibition is very important for us because that means that the bacteria was sensitive to bacitracin. And we know that pyogene is sensitive to bacitracin, right? So how is it performed? If we take the bacitracin disc, which is placed on blood agar, and after incubation, we see the zone of inhibition. If it is sensitive, the zone of inhibition is present, and we know this is the strep pyogenes, right? If there's no zone, we know that this is resistance. This is not group A, it's most often group B, which is strep agalactiae. Another test that we can do is PYR test. This is a much more uh, accurate modern test, right? Um, Now the PYR stands for pyrrolinodyl arylamidase. Don't memorize the full name, just know it's called PYR. Now the PYR test, basically we check if the organism produces this enzyme or not. If it produces this enzyme, we call it the PYR positive um, organism. Okay, so who is PYR positive? The group A strep pyogenes is PYR positive, and the other one, the enterococcus or the um, agalactiae, is basically, sorry, not the enterococcus, the agalactiae is basically negative, right? So remember that PYR positive in the organisms are basically group A strep. Another thing you can remember here, even though it's not part of the diagram here, is that the Enterococcus faecalis is also PYR positive. Now, who is PYR negative? Your strep agalactiae is PYR negative. So don't forget that. This is the main basis of this test. How is it performed? You basically add the PYR reagent, and if the enzyme is present, you get this bright red color that appears, right? Can you see this bright red color? This appears in a positive PYR organism where the PYR enzyme is present, right? If there's no enzyme, there's no change and it's negative. So can you see this here? This is positive, and this is where you have no change, right? And this is positive, you get this red color. But this is no change, right? Okay, now let's study the actual organism. All right, let's first see our Streptococcus pyogenes group A streptococci. You know that these are gram-positive cocci in chains. Seen that if you break down the name, pio means pus and genes means producing. So these are pus producing organisms. This organism loves causing pus around it. It gives us three types of diseases, and you can teach yourself to divide the group A streptococcus diseases into three major areas, and that's basically the direct infection, the toxin mediated infection, and the immune mediated infection. So this is the direct infection, this is the toxin mediated infection, and this is the immune mediated infection. The direct infections are basically like pharyngitis, which is your strep throat. You get fever, sore throat, tonsillar exudates, and tender cervical lymph nodes. And then cellulitis is also a direct infection of the skin and subcutaneous tissue. The skin becomes red, hot, tender, swollen. Impetigo is also a direct infection where there's a honey-colored crust, and children commonly get it. Then Erysipelas are also direct infections. It's a superficial skin infection which produces bright red raised border, well demarcated lesions, usually on the face or the legs. And then we move on to the toxin mediated diseases, right? So the toxin mediated diseases where the organism isn't just invading, it's producing the toxins. So the first one is scarlet fever. The scarlet fever is caused by erythrogenic toxin. So think that a strep throat plus an erythrogenic toxin will basically give you scarlet fever. In scarlet fever, it's very important to know you get this strawberry tongue. It's red tongue with prominent papillae, and it looks like a strawberry basically. And there's this sandpaper rash. It's a rough kind of a rash, and students describe it as touching fine sandpaper. There's also circumferential pallor around the mouth. It remains pale. There's a red face and a white ring around the mouth. It's a very classic clue. That's something for the scarlet fever. And then we have necrotizing fasciitis. Basically, the necrotizing fasciitis is a flesh-eating disease. The bacteria spreads along the fascia, skin, subcutaneous tissue, fascia, rapid destruction of all these three things. Emergency surgery is required. And then we have the streptococcal toxic shock-like syndrome. This is a massive cytokine release. It produces fever, hypotension, shock, organ failure. And then we move on to the immune-mediated diseases. Now, the bacteria at the immune-mediated level, the bacteria may already be gone, but the immune system is causing the damage. First of all, you have the acute rheumatic fever. This classically occurs after the strep throat, not after impetigo. It classically occurs after the strep throat. Why? Because antibodies against M protein cross-react with the heart, joints, skin, and brain. Okay? Antibodies against that M protein cross-react with the heart, joint, skin, and brain. This is called molecular mimicry. We use the Jones criteria for this. Jones is basically Jones. J is for joints. It causes migratory arthritis. O is actually a heart-shaped O, so it's a heart. It causes carditis. N is for nodules. E is for erythema marginatum, and S is for Sydenham chorea. Right, that's your Jones category for diagnosing acute rheumatic fever. Then you also have post-streptococcal glomerulonephritis. This is another kind of immune-mediated disease where this can occur after pharyngitis or impetigo, not like rheumatic fever. Rheumatic fever only occurs after strep throat, classically. But post-streptococcal glomerulonephritis classically occurs after pharyngitis and impetigo. The mechanism is that the immune complexes deposit in the kidneys, right? It produces cola-colored urine, hematuria, periorbital edema, and hypertension. That's your basically glomerulonephritis here. Virulence factors of S pyogenes are basically you have a hyaluronic acid capsule. What this capsule basically does is this is a human connective tissue also contains hyaluronic acid. So the capsule of this bacteria and the human connective tissue, which also contains hyaluronic acid, are very similar. So the capsule looks human and the immune system basically becomes fooled. This is called molecular camouflage, right? Then we have this M protein, and this M protein is very important because what it does, it blocks the phagocytosis. Without the M protein, this virus will become less virulent because the M protein helps to evade the phagocytosis. Antibodies to this M protein enhanced host defenses against the S pyogenes, but it can also give rise to rheumatic fever, right? Um, Antibodies against this M protein may protect against infection, but can cause rheumatic fever. That's like a double-edged sword we have to play with. The ASO titer, basically the anti-streptolysin O or anti-DNase B antibodies, indicate recent strep pyogenes infection. Why is it useful? This ASO titer or anti-DNase B antibodies is useful because the organism may be gone, but ASO remains elevated. So you get this hint of the fact that there's a recent strep infection. That's what high ASO titer will give you. It's used in diagnosing rheumatic fever. Anti-DNase B is another marker of previous group A streptococcal infection, and it's useful especially after the impetigo. Lab identification, we'll go back to our algorithm, which we said that this beta hemolysis was done, bacitracin was done. This was sensitive to bacitracin, and it was positive on the PYR test. Moving on to our Streptococcus agalactiae, which is basically group B. Group B, you can remember B is for babies. Where does it live? It lives in the normal flora of the vagina and GI tract. How does the baby get infected? The baby gets infected during delivery. The colonized mother passes it to the newborn through the birth canal. So when the newborn is exposed by the birth canal, it causes diseases in babies. So it causes neonatal sepsis, the baby becomes lethargic, it poorly feeds, and fever is present there. It causes neonatal pneumonia, there's respiratory distress soon after birth. It causes neonatal meningitis, one of the most common causes of meningitis in neonates. And one important test we can do is for the CAMP factor. This CAMP test, basically, what is this? The most important identification test is this group B. Streptococcus produces the CAMP factor, right? And what does the CAMP factor basically do? This CAMP factor works with toxins which are produced by by the Staphylococcus aureus. Okay, so remember that this CAMP factor works with toxins produced with Staph aureus to increase hemolysis, right? Imagine Staph aureus plus the CAMP factor leads to a big hemolysis zone. And this is basically the positive CAMP test. So we do the CAMP test in order to check if Strep agalactiae, the group B streptococcus is present. So you get a really big hemolysis zone when you do this CAM factor test. And then we also can do this PYR test. We've studied this. The PYR test is negative for group B streptococci, but group A, the PYR is positive. The Bassett-Rassen test also we have seen that the group B streptococci are resistant to it. In pregnancy screening, this is very important. Pregnant women are screened at 35 to 37 weeks of gestation using a vaginal swab or a rectal swab. If positive, we give these pregnant patients penicillin or ampicillin during labor. So during labor, we give them penicillin or ampicillin, and this prevents neonatal infection, right? I'll stop here.